Hello everyone, this is Dr. Madhusudan Rao and the program I teach medical students. Today the topic of my lesson is beta thalassemia major. It is the most common genetically inherited disorder, transmitted by autosomal recessive inheritance, resulting in the chronic hemolytic anemia, due to mutation of the gene that controls the synthesis of beta globin chain and presenting with variable clinical features. There have been more than 200 mutations of thalassemic gene. Nearly 3% of the world population carry this gene. Homozygosity manifests the disease because this is autosomal recessive inheritance. The child inherits one gene, defective gene from each parent, and manifest the disease as progressive anemia from the age of as early as 4 to 6 months. Let us talk about some salient features of this particular disorder with regard to clinical presentation, with regard to features specific for thalassemia and the features of secondary hemochromatosis. These are the objectives of this present lecture. Well, this is the picture of the child, 7-year-old male child, that has been suffering from beta thalassemia major. It is a neglected case, never attended for blood transfusions, and he lives in the tribal area. When you look at the child, there is facial dysmorphism with prominent frontal bossing, malar prominence, depressed nasal bridge, and growth failure. And this is again a child of about 4 years old, showing massive splenomegaly and severe anemia. Well, how do you define this particular disorder? Thalassemia major is genetically transmitted hemolytic anemia associated with diminished or absent production of beta globin chains with variable clinical presentation. You look into each component of this particular definition. A genetically transmitted hemolytic anemia. That means there is a defective gene that controls the synthesis of beta globin chains. Beta globin chains pairing with the alpha globin chain. 2 beta globin chains and 2 alpha globin chains. They constitute the adult hemoglobin. When there is a reduction in the formation of the beta globin chains, there is an imbalance that exists. That results in the excessive alpha globin chains, which form the inclusion bodies in the RBC, resulting in the premature lysis or destruction of these cells before they are released into the circulation. That phenomena is called ineffective erythropoiesis. There is, in response to anemia, there is excessive production of erythroid cell, RBC. There is, in response to hypoxemia, there is a production of the erythropoietin, which results in the hyperplasia of the erythroid tissue. There is great turnover of the RBC. resulting in a state of catabolism that results in the growth failure of the child. Okay? These are all the problems associated with this particular hemolytic anemia. So, to say a few points with regard to the introduction, it's the most common genetic disorder. More than 200 beta thalassemic variants are reported. Nearly 3% of the world population carry this gene for beta thalassemia. So, it's very high. The disease is common in the areas of malaria, areas endemic for malaria. There is remarkable shortening of the red cell lifespan because the red cells that are being produced in the bone marrow during the process of erythropoiesis, there is failure of formation of the beta globin chains and excess formation of the alpha globin chains form the inclusion bodies, thereby resulting in the premature lysis of the RBC before they are released into the circulation. Okay? There is great turnover of the RBC. This is called ineffective erythropoiesis. Okay? As a result of the reduced formation of the beta globin chains, there is increased gamma globin chains that results in the elevated fetal hemoglobin. Okay. Well, the progressive anemia resulting in the growth failure is treated with blood transfusions. Okay. The result is transfusion hemocelluloses. Look at this X-ray skull of the child with the beta thalassemia. In response to the anemia, elevated erythropoietin levels, there is hyperplasia of the erythroid tissue that results in the widening of the diplo of the skull bones, seen as the heron appearance, the lateral view of this skull. Well, as I told you before, it is genetically transmitted disorder, autosomal recessive inheritance. Okay, heterozygosity occurs in the parents. Homozygous state is the that manifests in the children. It could be thalassemia major or thalassemia intermediate or thalassemia minor, minima or minor or the trait, depending on the degree of anemia or degree of the suppression of the beta globin chains. The clinical manifestation child may present with the features of anemia in general, features of beta thalassemia, that is, features specific to beta thalassemia, or child may be neglected or subjected to the repeated transfusion, ultimately presenting as features with transfusion hemochromatosis. Okay. Features of anemia in general include growth failure, easy fatigability, exercise intolerance, pallor, or there may be jaundice, or ultimately child may be brought to you with the features of congestive heart failure. Features specific to beta thalassemia are the result of the erythroid hyperplasia with the widening of the marrow space, resulting in the bony deformities. They may be having the frontal bossing, depressed nasal bridge, okay, pathological fractures, etc. Features of transfusion hemocelluloses. They may present to you with the damage to the various endocrine glands, usually occurs 4 to 5 years following the transfusion therapy. They may present to you with features of diabetes mellitus, features of growth failure because of the growth hormone deficiency. They may present to you with gonadal deficiency, manifesting as the gynecomastia, etc. Okay. And features of hypothyroidism due to dysfunction of the thyroid gland, secondly to the deposition of iron. So the child may present to you, or the patient with beta thalassemia major may present during childhood with features of anemia amounting to congestive heart failure. And in course of time, there could be features of bony deformities secondary to the erythroid hyperplasia, which is specific for beta thalassemia major. Or later part of the life, they may present with features of transfusion hemochromatosis. This is the child on regular blood transfusions. And the management includes team approach in order to reduce the morbidity and mortality and improve the quality of life. How do you go about it? This is the pathogenesis of beta thalassemia, which we have already talked about. It is because of the impaired beta globin chain due to the mutation of the gene that controls the synthesis of beta globins. Okay, and there is relatively excess of alpha chains forming the tetramers, which form the inclusions in the red cells. That results in the early lysis of the RBC before they are released into the circulation. Okay, that is called ineffective erythropoiesis. The resulting anemia results in hypoxia. Hypoxia stimulates the erythropoietin secretion. That causes the erythroid hyperplasia and bony deformities. Okay. And extramedullary erythropoiesis results in the splenomegaly. Okay. Excessive absorption of iron from the gut, secondary to the reduced levels of hepcidin, results in secondary hemochromatosis. Okay. This is compounded by the regular blood transfusions. This is what happens in the child with beta thalassemia. Okay. If you examine the peripheral smear of the child with beta thalassemia, there could be microcytic hypochromasia with target cells, okay, poikilocytosis, anisocytosis, and eosinophilic stippling. You look at the X-ray chest of the child with thalassemia major. There is a cardiomegaly. The cardiomegaly could be due to anemia, congestive heart failure, or due to the cardiac hemochromatosis, resulting in dilated cardiomyopathy. This has already been discussed about. The child may present the features of hemochromatosis secondary to iron involvement. There could be hepatic dysfunction in the form of elevated liver enzymes. Okay, there could be hepatomegaly or could be jaundice. There could be features of hypothyroidism due to the injury to the thyroid gland. Diabetes mellitus, growth hormone deficiency, gonadal failure, etc. Cardiac dysfunction sets in about around 8 years following the regular transfusion therapy. This is the peripheral smear of the child with thalassemia major. So there could be regular laboratory evaluation of the patient on treatment. You monitor the hemoglobin levels in order to maintain the hemoglobin around 9.5 to 10 grams per cent. So that will be having beneficial effect in order to promote growth, reduce bone changes, and improving the quality of life. Well, reticulocyte count. Reticulocyte count is relatively low when compared to the anemia because of the ineffective erythropoiesis. And it could be around 8%, not more than that, in patients with beta thalassemia major. There is microcytosis with hypochondria with presence of target cells. Serum bilirubin may be elevated or there could be elevated hepatic enzymes. If you look into the serum iron, it is elevated. Okay. And serum ferritin levels is the gold standard for assessment of the total body iron stores. And serum ferritin levels should be brought down to 50 to 100 micrograms per liter with the iron chelation therapy. But in the child with the hemochromatosis and the patient on regular transfusions, it could be as high as more than 1000 micrograms per liter, that causing the damage to the organ system due to secondary hemochromatosis. The bone marrow examination shows the erythroid hyperplasia with normal myelopiosis. Okay. Radiographs may show the presence of pathological fractures or X-ray skull may show the hair and appearance. And hemoglobin erythropoiesis is diagnostic, showing elevated fetal hemoglobin and elevated HbA2 and low adult hemoglobin. While the patient is on your treatment, the patient should be monitored and for cardiac dysfunction secondary to the cardiac hemochromatosis, which is set in around 8 years following the transfusion therapy. The MRI of the heart will tell you the degree of hemochromatosis. Endocrinopathies in the form of hypothyroidism, diabetes mellitus, growth failure will set in around 3 to 5 years following the initiation of the chronic transfusion therapy. And while the patient is on regular transfusions, supplement with folic acid, okay, avoid iron containing foods, initiate iron chelation with deferoxamine or deferriprone or deferrosilox. Deferriprone is used for cardiac hemochromatosis. Okay. And hydroxyurea does not have much role in the treatment of beta thalassemia major, but it has got some role to reduce the thromboembolic phenomena in the patients with thalassemia intermediate. And patients with recurrent hypersplenism and massive splenomegaly with increased frequency of transfusions are advised for splenectomy. Okay. And there is risk of splenectomy, risk of sepsis, development of pulmonary hypertension, and venous thrombosis. Well, the current line of management of beta thalassemia major is hemopoietic stem cell transplantation. You should get the HLA matching sibling. There should not be any splenomegaly or hepatomegaly, and serum iron levels should be normal. With these criteria being fulfilled, with preparing the child with myeloablation, and stem cell transplantation is going to show success in more than 90% of the patients with thalassemia major. This has been done in many centers, and success rate is more than 90%. And this is the current mode of treatment for the patients with incurable thalassemia major. We can look into the splenectomy. The massive splenectomy with features of hypersplenism, falling hemoglobin, raising transfusion frequency. Even though the risk for sepsis, venothrombosis, stroke, leg ulcers, and pulmonary hypertension, splenectomy is carried out in some of the patients with massive splenomegaly. Okay, and monitored regularly in order to look for the complications. Okay. By and large, these children They suffer with great degree of morbidity and mortality. Thank you very much for patient listening. We'll meet you again in the next class. Until that time, bye-bye. And to add a note, one important point is counseling the parents is of paramount importance in order to provide the psychological support. Okay. Yeah. Family participation is very much required in order to manage the children with this incurable disorder associated with a great degree of morbidity and mortality. Thank you again for patient listening. We'll meet you in the next class. Until that time, bye-bye.